two questions. If a patient presents to the emergency room with a DVT, I know it's patient specific, but is there a certain specific patient that we can start them on, like Xarelto and discharge rather than admit, versus those that you have to admit?
So we don't have to admit DVTs, like for sure, all DVTs. That the way that the practical. At first, you have to look at your health system setting where you're serving the patient and what setting you're providing the service. So I think it's very individualized to that particular setting that you. I used to work in Southside in Trinity, so I'm working now in Evanston and Highland Park, so I can tell you that if I'm I never practiced as a vascular medicine specialist in Trinity, but in a different setting, the way that the system setting, the follow-up setting, I think we have to be careful that if we're deciding to approach the patient for outpatient treatment, so we are having the system set up. But in general, all the distal DVTs, what do I mean the distal? From popliteal below the popliteal vein can be easily handled as an outpatient, as long as that you review a couple things about patient. This patient is a suitable candidate for anticoagulation, appropriate dosing of anticoagulation is being given to the patient, and then appropriate follow-up for the patient, set up. So, and then for the more proximal DVTs, I would go like individualized, especially if you have a patient with iliofemoral DVT. I would hesitate to treat those patients as an outpatient. A group of these patients, they may need intervention. When you see the iliofemoral DVT, you always need to think about the outflow obstruction, either due to vascular compression or tumor compression. You always need to take the next step. And if those are not done in the emergency room, sending a patient home usually would be a challenge. And the small group of patients with the outflow obstruction DVTs, they may come with a limb ischemia due to DVT. We call it phlegmasia. So that small group, which rarely happen, for sure shouldn't be outside the hospital. So they have to be in a hospital, and basically will like limb-threatening DVT, facing a limb-threatening DVT. So
my last question was, if a person's going to have a procedure for the DOACs, like Xarelto or Eliquis, is there a certain time that you have to stop it?
So we have multiple guidelines written from different societies. So what I came to adaption is that if you go in for a surgery, and surgery is the major surgeries, we're talking about major surgeries. If in a major surgeries, if I'm going to ask it very like a brief answer, major surgeries that you go for general anesthesia, and assuming you have a normal kidney function, I think 48 hours for anti-10A inhibitors would be enough, mostly. So for rivaroxaban and apixaban, we may need to hold it a little longer, up to 36 hours to 48 hours for bevacizumab. It's not like in the market much. But if you are having a neuroaxial anesthesia, I would hold it for 3 days. So not earlier than 3 days for neuroaxial. And anesthesia will demand that, definitely is part of their guideline for neuroaxials. For neuroaxial, we'll just do 3 days.
Practical question, either of you, physical therapists. Post-op advice. What do you think about the use of TEDOs or some of those gadgets, or baby aspirin? What do you think is really the best advice?
For the patient with DVT?
Post-op, just post-op. Just
Post-op?
preventative.
Oh, for a patient that revascularized?
Just, I think it's very normal now for like even a scope, the post-op scope, shoulder knee, put them on baby aspirin prophylactically.
Well, I mean, the post-operative, venous thromboembolism prevention, I hope we can have one session about just for this, is a big sort of, topic in very, very large spectrum. We cannot generalize that. But, so there's a group of patients that they do not need any post-operative venous thromboembolism prevention. So they're the one that they need a primary prevention, and the one that they need secondary prevention. So I think it's a very large topic, and I think that's big part of my practice. Big part of my practice, we are basically serving the surgeons about what to do to not get venous thromboembolism. What I can recommend is that one of the most broadly validated score that you can use is Caprini score. You can use Caprini score. Joe Caprini, he retired at North Shore. He's very well known. 3 million patient validated on 3 million patient about what to do to prevent the venous thromboembolism based on Dr. Caprini's score. You can always, there is an app called Clot Aware. If you download that Clot Aware, has the Joe Caprini score on it, you can get, and it can exactly give you the score. I would say for a score above 8, for sure I would use preventive anticoagulation for an extended course to prevent venous thromboembolism. So that's what, that's, I can just give you one word answer. It's lots into it. Yeah.
Oh, that's good, yeah.
I mean, for me, without calculating that score, which I think is probably the most educated way to do, to determine whether to use some type of, DVT prevention. If the patient, orthopedic procedures are the highest risk, like hips and knees, right? So they're gonna need something, and it's good for that. But if the patient is gonna be, if it depends on, if they're gonna be bed bound, it's an automatic also. So it's very patient specific. But if the patient is gonna be ambulatory right afterwards, then a lot of times you don't necessarily need it because they're like the outpatients, right? Now, do they need a TED hose? Not necessarily. But if they're ambulatory, a lot of
Saying
times.
more doctors just do the baby aspirin because they've had one case where things went bad, right?
Yeah, post-operative DVTs, they can happen up to 6 weeks.
Yeah.
Now, we just see it, and easily you can look back. I'll give you an example. If you have a patient with a prior history of DVT, or patient with family history of DVT, going for lower extremity interventions of surgeries, you most likely need extended course.
Yeah.
If the patient going for a general anesthesia with family history plus or prior history of DVT, you need extended course of the treatment. So on surgical patients, we're coming to agreement after years. Now the focus on the medical patient, and we're just getting more and more data on medical patient. Even the patients that get admitted 10 days in ICU now going home. So what to do? And the data is growing that support that we need to consider the extended course on those patients. So it's not about like just only reducing the mortality, but it's a consequence of these thromboses and the cost that can be prevented in the beginning with very low risk.
Great. Well, thank you so much.